Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hi, everyone. Welcome. My name is Dr. Chen, Physician Director of Practice Sustainability here at the AMA. On today's podcast, I'm joined by Dr. Sarah Coles, a family medicine physician, member of the American Academy of Family Physicians, and program director for the Family and Community Medicine Residency at North Country Healthcare in Arizona. Dr. Coles is also an associate professor in the Department of Family, Community, and Preventative Medicine at the University of Arizona College of Medicine, Phoenix. Thank you so much today for joining us, Dr. Coles.
Thank you. It's my pleasure being here.
So to begin, our topic of discussion today is Dr. Coles' behavioral health integration experience from the hybrid model adoption to implementation to finding sustainable success in practice. Before we get started, Dr. Coles, can you tell us a little bit more about yourself?
Yeah, absolutely. So as you mentioned, I am a family doc with a particular interest now in integrated behavioral health and treatment of mental health conditions in the primary care setting. I really love evidence-based medicine and population and community health. So doing integrated behavioral health is just a true joy and something I'm really thrilled to get to talk about today.
That's awesome. I'd love to hear more about your behavioral health integration successes and insights. But could you share first how you and your colleagues identified the need for behavioral health integration, and how did you make the case to your leadership that this was an important topic?
Yeah, absolutely. I would really love to claim credit for identifying the need in our practice, but I truly can't. It wasn't me. We had a really visionary department chair and medical director who saw the need as well as opportunity for a potential funding source. And this is when they brought me in. So I'm truly grateful for them, for these folks who think about kind of large practice models and sustainability in our practice, folks like you, who can see that kind of need and then bring in other folks. Prior to this, I had really no experience with integrated behavioral health, but was excited to jump in and just kind of learn the ropes as I go. I think everyone in our practice realized pretty early on and pretty quickly that our patients with mental and behavioral health disorders were struggling. Like in many places, more than half of our patients who were referred to psychiatry never went or would never had the opportunity to be seen by a psychiatrist. I live in Arizona, and in Arizona, only about 40% of adult patients with any mental health disorder receive any form of treatment from anyone, including primary care. So that included a large number of our patients as well. In Arizona as well, we also had a huge shortage of psychiatrists who were available to see patients, particularly psychiatrists who were available to see uninsured or patients who have Medicaid or Medicare insurance, which is our predominant population. I work in rural and urban underserved clinic practices. So we saw that our patients weren't getting the care that they needed. And despite our desire to help these folks to provide high quality behavioral health care and to help them reach the outcomes that they wanted to reach, we weren't succeeding. We were failing our patients in our practice, and we really wanted to do better. Even further, we knew that our patients were having a lot of struggles, not just connecting to psychiatry, but if they could connect, even getting there. They had a lot of social drivers of health that would make this challenging. Things like getting transportation to an additional doctor's appointment, getting money to pay for a copay for a subspecialist appointment, getting time off of work or caregiving, or just other life things that would come and get in the way for our patients of receiving care. And then importantly, our patients felt a lot of stigma, as many communities do, in going to see psychiatry. They wanted to stay where they felt safest, in their primary care medical home, and they wouldn't have to go someplace else where they might be seen entering a psychiatrist's office and someone might label them or judge them, and then they would have that kind of concern. So we saw this all happening in our practice and wanted to do better. We wanted to be a better place to provide that care for our patients and to improve those outcomes for them. So we jumped into the integrated behavioral health model bandwagon. We realized that this was the way to go. Our physician teams saw we were spending lots of time treating mental health disorders without the outcome improvement that we wanted to see. And sometimes we were doing this to the exclusion of other things we needed to be taken care of, like chronic, acute, or preventive health needs. So our patients were struggling, our clinical teams were struggling, and then ultimately our financial sustainability was struggling. So we saw that we weren't meeting our quality metrics for our value-based contracts because we were spending a lot of time spinning our wheels trying to get someone's depression under control. I think often of a patient I have who is an older gal who has uncontrolled depression or had uncontrolled depression, along with a number of other uncontrolled illnesses. Every time I would see her, we were spending so much time focusing on depression. We never talked about her diabetes or her high blood pressure or acute low back pain or all these other things because the depression was what mattered. And so my metrics looked terrible for her because we couldn't get there because she had this huge barrier. So we got to put this all together and saw the problem. And then, as you said, needed to make the case to leadership. Why should somebody invest in building a solution to this when we have lots of other things that are drawing our attention, our finances, our resources away, and could be also very important needs? So we ran our numbers. We saw that our patients had a lot of uncontrolled mental illness in our particular population, and that those corresponded with a significant amount of uncontrolled disease states and unmet negative social drivers of health. So we demonstrated these high rates. We saw how we were failing our patients to improve these cares. We demonstrated how there were health inequities in our practice, that certain patients had worse outcomes than others in our practice, that we had worsened chronic disease state control for these patients as well, that our bottom line was impacted by not meeting our value-based care contracts, and that it was impacting our clinician team, our sense of satisfaction and wellness and joy in our work. And so there was a potential impact on recruitment and clinician retention as well. So we gave all of these numbers to leadership who agreed, yes, this is a problem. This is something that we need to invest in.
That was wonderful information and insights. What kind of models for integration did you consider, and what ultimately did you decide on, and why?
We looked at lots of models. We looked at co-located care. We looked at just increasing our referral patterns and connections to community resources. We looked at collaborative care model, amongst others. But the first thing we needed to do was set our goal. What were we hoping to achieve? And this was going to help us decide what model would be most effective for us and our patients. So the goal we said, we want an evidence-based approach to improve behavioral health care within our primary care setting that was feasible to build in a teaching practice, is financially sustainable, and is acceptable to patients, administrators, staff, and clinicians. So once we did our goal setting, we then made sure we had all of our stakeholders on board and that they agreed with these goals and there wasn't anything we were missing. So we gathered our primary care team, our psychiatry teams, our psychology teams, our pharmacists, our social workers, our MAs and nurses, our front office staff, our administrators, everybody who had a hand in providing behavioral health care and primary care in our practice to really look at this and see, are there different areas that we should be considering? And after all of that was said and done, we landed on the collaborative care model as our ultimate model that we pursued and ultimately built in our practice. This model is unique and particularly effective in primary care settings. It was developed by the University of Washington Ames Center and allows us to treat common mental health disorders in our primary care setting, which was a key part of one of our goals, was retaining our patients where they feel safe and trusted. And it had all of the elements that we already had in place and could build upon. So, of course, it requires a primary care physician who will direct and provide that care. So check, we had that. It required a psychiatric consultant who would do indirect care and provide consultative and review services. Check, we had that. And lastly, it required a behavioral health care manager. This was something we did not yet have. And the care manager is the most important part of a collaborative care model. They are the linchpin of everything collaborative care. They have to do so much work and are such incredible folks, but they perform assessments and systematic follow-ups. They do the bulk of the documentation. They provide patient education. They update and implement treatment plans. They can perform brief and evidence-based psychological intervention. They can integrate other care needs and work across subspecialties and community resources to ensure that patients are getting the care that they need. And so this felt like something that would really benefit our patients who had so many social drivers of health that they were facing, and would allow us to increase the touch points for our patients. And then, of course, the fourth and most important person in a collaborative care model is the patient, who drives the care goals and treatment plan. And we had plenty of those. So we were ready to kind of put this model into place for us. The collaborative care model is also really evidence-based, and that was something that's really critical for us, particularly in a residency and teaching setting. There are so many studies demonstrating the efficacy of a collaborative care model, over 90 RCTs, tons of systematic reviews, lots of data out there that this is highly effective. The number that got me, that I think really was like, oh, we have to do this in our practice, was the time to remission for patients with depression who have participated in a collaborative care model versus usual care. So if they're in our usual primary care setting, the time to remission is about 614 days, which is a very long time to continue to have uncontrolled depression. But for folks participating in collaborative care, it's only 86 days. And that's bananas. That's an incredible improvement. And we wanted to be able to provide that for our patients. So the collaborative care model seemed like a win-win-win for all of us.
That's great. After adopting the collaborative care model, I know it takes a while to ramp things up and it takes a little while to get things rolling. How long did it take approximately for you to start to see results? Things like patient metrics improving, or even, just a gestalt feel of, hey, my patients are actually benefiting right here and right now. About how long did that take?
Honestly, it was pretty quick. It was very, very fast to start to see some results. As you said, there is an initial investment in time, energy, and resources to get it started. So we did rely initially on external funding sources to hire that care manager and to pay for that psychiatrist's time to provide that consultative exchange. We had to use that money as well to help us build the program, so to build the workflows, to train everybody on how to do this kind of care, to make sure everyone felt comfortable providing behavioral health care in a primary care setting, because not every family physician or primary care doc feels really ready to go with this kind of care. And then to do all sorts of little plan, do, study, act cycles where we tried something, it didn't work, we tried something, it didn't work, until we landed on what did. But ultimately, within the first year of implementing this program, we saw huge successes. We saw improvements in patient metrics. We saw increased clinician satisfaction. We saw patient increased satisfaction. And we were already starting to see the financial benefit of implementing this model. By year 3, it was undeniable that this was a successful model. So by the end of year 3, we had treated over 300 patients in this model, had cut our initial PHQ-9s and GAD-7s in half for our patients, which is incredible. We saw our clinicians being really thrilled to participate in this care and really engaging in it, actively seeking opportunities to send more patients to collaborative care and to work more closely with our care manager and psychiatrists. And then we also saw reductions in physical health metrics. So we saw improvements in our A1Cs for our patients who had diabetes, for our blood pressure, for our patients who have hypertension. We really saw this very rapidly to excel in our program.
You mentioned that, the financials were there after year 1 and even, beyond. So what does that sustainability sort of look like to you at this point? And how were you able to basically get to that point?
Yeah, it takes a little bit of time to get to that financial sustainability, as we said. So that wasn't on day one. But as you said, by the end of year 1 to 3, we started to see it. And it depends a little on the complexity of the care that you are providing. So in our practice, our collaborative care model was seeing moderately to high complexity patients. So our care navigator was spending a lot more time with these patients than perhaps in another primary care practice that implements a collaborative care model that maybe has low to moderate complexity care patient needs. So she had a lot of touch points, about 3 to 4 touch points per month for every patient, which means we needed a smaller panel of patients in order for this to be financially feasible and sustainable. About 50 to 80 patients on her registry panel at any given time. We really capped out for a while at about 30 patients for a number of reasons as we were kind of building this model in place. And so we recognized that we needed to adapt a little bit what we were doing to make this more feasible. Some practices will expand into multiple clinics to split that FTE for that care manager to make it a financially sustainable model. We did also include other clinics in our collaborative care program, including our internal medicine residency clinic, to bolster that patient number as well and to provide that service to those patients who also needed that care. But we also realized what we could do was expand the model and adapt the model to other patients in our practice who would benefit from care. So for us, it was folks with substance use disorders and ADHD. So we had just built an addiction medicine fellowship, and we're training our primary care docs on how to manage substance use disorders for folks, particularly opioid use disorder. And this was a really perfect fit and is also evidence-based to improve outcomes for folks with opioid use disorder. So we were able to bolster that population and provide additional care services and make it financially feasible for our practice. We also demonstrated, because we were a part of a larger healthcare system, savings for the rest of the system. So decreased hospitalization, decreased ER utilization, improved quality metrics to improve our value-based care contract payouts. So while we didn't necessarily always get to the top of our revenue stream that we would like with that care panel management, we demonstrated those financial savings elsewhere to make up any additional needs.
Got it. Switching gears a little bit, Dr. Coles, given your role, in your residency programs as a physician educator, how did you incorporate, this collaborative care model, behavioral integration? How did you incorporate that into teaching your trainees and helping them with their careers moving forward?
One of the best things about collaborative care, because there's so many best things about collaborative care, is that it is inherently educational. It is built on educating every member of that team to provide the highest quality of care to the highest scope of practice for everyone involved. So it was a real perfect fit for us because we really did want to integrate our learners, our residents, and our medical students, and really any other learners that we had in our office to learn how to do this kind of care. So every time our psychiatrist would review a case with our PCP or our care manager, she took extra care to make sure that we were learning something. She would write in her note an important piece of learning for us every time, of fun, quirky information about dosing for this medication, how this might interact with a comorbid condition, and other things we might be considering. She always made sure to make every comment she made valuable to us. And so we saw, as we participated in this program, that not just our residents improved in their behavioral healthcare knowledge and management, but our faculty did too. I certainly learned a ton doing this type of care and working so closely with our psychiatrist and care manager because they spent so much time teaching us. We asked our residents how they felt about the collaborative care program and how it impacted their education, and they universally agreed that it was positive. Several commented about how they felt like they could expand their scope and provide care for disease states that they might have otherwise referred. They felt way more comfortable with medication management when maybe they had been a little bit more hesitant in the past. They felt way more comfortable talking to patients about their mental health conditions and how they might manage it both pharmacologically and non-pharmacologically. And they felt like when they graduated, they could go on to do this work in their future practice, that they could lead and build integrated behavioral health teams because it is so critical and so underutilized across our health systems. So it really was very valuable. We also spent a lot of time teaching specifically for this model, doing didactic sessions, having our residents and learners participate in those care communication pathways. So they're the ones giving advice to each other, talking to the psychiatrist, documenting those notes so they knew how it worked. We made sure they understood billing and coding because it's very important that we are able to get paid for the work that we're doing so we can build these kinds of programs elsewhere. And then how to make this case to leadership. How do they go out and sell the importance of integrated behavioral health wherever they go practice so they can build these types of programs? So we felt really, truly lucky to get to participate in this as a teaching facility because it was so inherently valuable for every member of the team.
That is such a hopeful outlook for the future of medicine. That's wonderful. I'm glad that your learners have been so enthusiastic about the program. Are there any practical tips or pearls of wisdom for healthcare leaders such as yourself, but are just starting out to enhance their journey towards, this behavioral health integration? What have you learned? What would be your top advice points for them?
I think number one is identify champions. Find someone who is passionate about doing this work. Get your stakeholders and key team together. Everyone needs to be brought in for this work to be successful. So identify those folks and get them involved right away. I also learned how important it is to train and train again and train again. It is an iterative process where just when you think you've got it right, something new will pop up or there'll be a new idea or a new problem to solve. So you want to keep doing more training, more opportunities, more of those PDSA learning cycles, and know that that's great and okay. It's never done. There's always more to build and improve and to learn. I also think it's really important to make it psychologically safe for everyone in your team as you're building this kind of new model to have that critical feedback, because this can be an uncomfortable transition for everybody into a new type of practice, maybe an expanded scope of care, a different way to provide care than we've traditionally been trained to do. So it can be really hard, and not everyone may feel safe telling you where their pain points are or challenges are. So we want to make sure that everybody has the opportunity to psychologically safe, tell you what's working, what's not working, how we can improve. So ask for feedback often, implement what you can, explain clearly if you can't, but how you might help to mitigate any problems that people are facing, and make sure that every single member of the team has that opportunity all the time. And then the last and I think most important lesson I learned in doing this process is you don't need to be an expert. I had no idea what I was doing when I got started in this, other than I was a family physician who really valued comprehensive primary care and wanted to do well for our patients. But I had no particular expertise in mental health care or integrated behavioral health care before I got started in this. And please don't let that stop you. We all have that little imposter syndrome voice in our head that says, why is this you? Maybe you aren't the right person. What business do you have doing this? And you have every business and all the knowledge that you need to make this work. So please don't give up. Please get started. Wherever level you're at is the right level to start with, and there is resources out there to help you get wherever you need to be, and you can do this successfully in your practice.
Well, I want to thank you so much for joining us today, Dr. Coles, and I want to thank our listeners for tuning in as well. Listeners can find the resources mentioned today in today's episode in the episode description. Everybody have a great day.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.